as a resource for other healthcare professionals, this book is useful because it gives a perspective, an optometric perspective into these cases, but in a way that psychology, speech pathology, occupational therapy, physiotherapy, a lot of other professions can read this book and say, okay, I can see how this clicks into what we're doing in our clinic. We collaborate a lot with OTs and speech paths because you can have reading issues that are both dysphonetic, so they're based in phonics. There really is an actual phonetic issue. That will be the child who will not spell station how it sounds. They'll spell it with P's and Q's, and you're scratching your head going, this kid does not have a clue how sound and letters go together. So that needs a speech pathology intervention. There's no doubt about that. But if the child is persistently phonetically spelling, then the speech path is going to eventually hit a brick wall where they're saying, this kid's improved, I've helped them, I've gotten them from 1 out of 10 to 4 out of 10, but they seem to be hitting a brick wall. So that speech pathologist could potentially just say, okay, I've gotten your kid as good as I can get them, say to the parent, you need to read this book because I think there's another component going on here. So the reading issue can be dysphonetic or it can be dyseidetic, which is our terminology for a visual memory-based reading issue. So that's typically involves the oculomotor system. So different professionals can look at this book and use it a different way, but I think psychology, speech pathology, OT and PT, I think in particular, would benefit from a health profession standpoint, and of course the family doctor. The family physician may be dealing with a parent who brings a child in. For example, they might say, my child has a headache, and it's always at the end of school, or my child has difficulty concentrating at school. Maybe they have ADD. Do they have an attentional problem? So ADD really is a symptom-based diagnosis. There's no blood test, there's no MRI, there's no objective testing for it. It's really a questionnaire, either the Conners Rating Scale, the DSM-5, and if you look at the symptoms of oculomotor dysfunction, just based on there's a paper published, I think it was 2005, where they showed that on the DSM-4, which is now the DSM-5, the DSM-4, 5 out of the 9 DSM criteria alone would be present in an oculomotor problem. So you've got more than 50% of the symptoms for ADD being triggered by an oculomotor type of problem. So you've got to be aware of that link. So the family doctor who has a child who presents with a headache, usually they're frontal and usually they're more prominent towards the end of the day, so it's a fatigue pattern. It's not like they wake up with them, which is typically could be neck or back, or it could be high intracranial pressure if it's something more serious. Usually if it's a fatigue effect, it's typically not there in the morning. It usually builds as the day goes on, and usually by the end of the day, the kids they have a fuse this short. And usually attentional issues are building as the day goes on. So it's usually pretty easy to spot these headache patterns. So I think a physician, I would assume that a lot of complaints of headaches in general with children that are not explained, it probably makes up a fair amount of cases that present to a family doctor's office.